Good morning, everyone. Welcome back to our list today. The topic is on TCM treatment for PTSD, and my name is Donna Chow, and I'll be your host and your moderator for today's event. So how many of you have attended yesterday's webinar on the TCM treatment of brain injury? Okay, it looks like majority of people here did attend yesterday, so welcome back. And hello to everyone that's just joining us for today's class. On behalf of eLotus, I'd like to welcome you and thank you for choosing Lotus Institute of Integrative Medicine as your CEU provider. We have been holding educational courses for over 20 years, and we are proud to be your trusted source for premium CEU content. I'd also like to take this time to thank Evergreen Herbs as well as their customers. Because of you, we are able to hold special promotional events and freebies throughout the year. When you choose Evergreen as your herb provider, you're also choosing to invest in the advancement of TCM. Thank you for being part of a great collective. Helping each other is a domino effect and the key to succeeding together. Before we begin, I would like to cover a few housekeeping topics. We are scheduled to end at 6 p.m. Pacific time today. Lunch is 1 to 2 p.m. and we have 2 breaks in the morning and 2 in the afternoon. Now let me give you an overview of our webinar room. You'll see the video feed on the top left-hand corner, and I do want to remind you that we are broadcasting remotely today due to current events of COVID-19. So if there is a dropout from the speaker's end, then it would affect everyone, but don't even worry about that because Douglas is an expert at this. He knows how to get back online, so your CEUs will not be affected. So to the right of the video feed, you'll find the PowerPoint for today's class. A copy of these slides can be found in PDF form from the course access page. Under the video feed, you will find the chat room. Here, you are welcome to connect with your colleagues who are also attending today's class live. For any side chatter, feel free to private chat. You can do this by clicking on the menu icon at the top right-hand corner of the chat room. The menu icon looks like a bunch of horizontal lines with an upside down triangle. If you have any questions regarding your account or technical issues, please feel free to start a private chat with host. That's H-O-S-T, host. If you do have questions for our speaker, please type them directly into the chat room. He'll be able to see it while presenting. And please do keep your questions related to the topic that he is currently presenting. All right, let's get started with today's class on TCM treatments for PTSD with Douglas Wingate. Douglas specializes in the treatment of concussion and brain injury and is involved in research through the Oregon Health Science University in treatment protocols for peripheral and polyneuropathies. He has volunteered with and served on the board of multiple nonprofits in the Portland area serving veterans and individuals with effects of brain injuries. All right, so let's go ahead and have Douglas connect with us here, and if you can share your video. Perfect. Go ahead and do a quick testing for us.
All right, morning. Just want to check the audio there. Can you hear me?
Yes, we can hear you.
Okay, perfect. Morning, Donna. Morning, everybody else. All right. So it looks like a good number of you joined me yesterday for the brain injury talk, so that's great. That'll be a helpful foundation for a lot of the material that we're covering today. Give you a little bit of a reprieve when we get into some of the pathogenic factors. And for those joining us that did not make the seminar yesterday, welcome. Thank you for joining us and taking time out of your day and accommodating everything given the COVID-19 situation. So today we are going to go through and talk about the TCM treatment for PTSD. Let's see. And just check in for those who did attend yesterday. If you've got any questions after a big long day of information and it's not too far off topic of today's discussion, we can go ahead and address that. Anytime that you have any questions that do come up, feel free to type them down in the text box down there. I'll try to address those either as we go or catch up on those following each break. I'm going to shoot for the breaks at about 10:30 and 11:45 this morning, and about 3 o'clock and 4:30 this afternoon. As Donna mentioned, we're going to have a lunch from 1 to 2 o'clock. So And if you have anything in particular that you're interested in, or going into this, there's something that you would really like covered, I will do my best to do that. So go ahead and put that in there. It sounds like volume may be too high for somebody. If that's a consistent thing for everybody, go ahead and let me know, and I'll adjust the volume just a little bit. Right. It should be at the same level as yesterday as far as I'm aware. All right. So shall we get right into it? So as I said, today we're talking about PTSD, we're talking about trauma and how to address that from the Chinese medical lens, what TCM has to offer as far as PTSD and trauma treatments. In my practice, I do treat a lot of PTSD. A lot of times that's a comorbidity with the brain injury. As we discussed last time, a lot of the time there can be an emotional event, an emotional trauma that impacts physically, and there can be a physical trauma that impacts oneself emotionally, and there can be dual traumas that happen simultaneously. So a lot of the time, I'm seeing in my practice a lot of overlap on these sorts of things. I do definitely see people strictly PTSD, some people strictly brain injury, but we'll see as we get in the material, there are stark differences, and then there are some areas where there's a lot of overlap and really not that different, because as we'll see, emotional trauma has a very physiological effect. All right, so as an introduction to trauma, go ahead and provide this quote from the book, The Body Keeps the Score, Brain, Mind, and Body in the Healing of Trauma. Fantastic book if you are treating a lot of trauma. And the author goes to say, we have learned that trauma is not just an event that took place sometime in the past. It's also the imprint left by that experience on the mind, the brain, and the body. And we'll cover all of those. This imprint has ongoing consequences for how the human organism manages to survive in the present. Trauma results in a fundamental reorganization of the way mind and brain manage perceptions. It changes not only how we think and what we think about it, but also our very capacity to think. So, as we'll see, trauma of any kind, emotional trauma, has a very broad impact on somebody's life, and we're going to get into each detail of that. And then during the second half of today, or the first half, we'll kind of focus on what PTSD is, how it comes about, factors that can play into it or predispose you to developing PTSD when exposed to a trauma, and some of the major pathogenic factors that play into it. And then this afternoon, for the second half, we'll get primarily into the treatment protocols and how Chinese medicine works to address that. All right, so what defines PTSD? What makes something PTSD? Because there's trauma, somebody experiences a trauma, and they can be affected to various levels of it. What defines it and makes it actually qualify for PTSD? So, excuse me. PTSD is the after effect of a stressful situation that can cause a chronic multidimensional complex of emotional and physical symptoms in which one re-experiences an overwhelming traumatic event. This causes intense fear for the person. They can feel very helpless. They can have a sense of horror and general avoidance of stimuli, different components that might be associated with the trauma or bring on feelings that they associate with the trauma. So it may not even be direct experiences or direct stimuli that were involved. Sometimes it's the environments. Sometimes it's similar environments or similar situations, or if, for instance, it involves there's a trauma that involves a particular person, even hearing somebody that sounds like they have a similar voice, these other components that are just relatively close enough to bring on that feeling of fear, helplessness, and horror. All of that can play into it. So all of that is in play within PTSD, and PTSD itself acts as a continuation and magnification of anxiety-related symptoms that fit into 3 primary symptom clusters. So the big 3 that define it and make it PTSD are some sort of re-experiencing of the event on some level, and we'll go into each one of these in more detail, but do keep in mind that these are the big 3: re-experiencing, some sort of avoidance symptoms, and a general state of hyperarousal in some sense, and we'll talk about the details of that and what exactly that means as well. So in order to meet diagnostic criteria to be considered PTSD, these symptoms have to have been in place for at least a month, and they have to be considered severe enough to have impaired the individual's ability to function on a social, occupational, or other important life arena. Okay. Yeah, again, if you're losing sound on your end, well, if you're losing sound, chances are it's on your end. If it's consistent, I'll go ahead and address it. If I need to log off, log back in. But do go ahead and check your connection and see if that's maybe impacting it. So what you're looking at here is, and again, this is the standard definition of PTSD according to the DSM-5. So if somebody comes in and they formally reach that diagnosis, then you know that it's been there for a decent amount of time, at least a month's time, and that it is having some significant impact on their ability to function in some capacity of their life. And as a result, you are seeking chronic care. Let's see. It's usually because username. Okay. Sorry, just making sure everything's up and going okay. All right. So, as we said, one of the 3 key components that defines PTSD is that they re-experience the traumatic event to some degree on some level, and that can happen in multiple capacities, and it can definitely be, it can vary a lot in severity as well as far as what that that re-experiencing is and how close that is to the actual traumatic event or traumatic events, if there are plural or if it's a recurrent trauma. And we'll get into differences between different sorts of traumas. So if it's an early childhood trauma versus something that happened in somebody's later life and adulthood, or if it happened within a community setting or as a large group, community traumas, each of those are slightly different. I mean, they often have very similar impacts on an individual, but because of the environment that they occurred in, they can have small variances. So as far as re-experiencing, it can come as either an involuntary, unbidden, unexpected, intrusive thoughts within the individual. So they'll just not be able to get away from the ability to think about the situation or the trauma that happened. And if this can be very difficult for somebody because it's just a non-stop thing, and so it's a rumination. And of course, as Chinese medical practitioners, thoughts automatically go to the spleen organ and its ability to transform thoughts and move it through, and ultimately digest and transport those things through the earth element. It can be rather difficult for these individuals as it's just a continual thought process, and the brain does not really shut down. It's just continuing to bring that up, and sometimes fairly randomly. Sometimes it can be triggered by different events or environmental situations and things like that. They may also re-experience in the form of a traumatic declarative, visual or verbal memory, or somatically experienced. So a somatic memory is where they may go through a particular emotion, or they may move in a certain way, or they may it may be a sensory experience as well. So, for instance, a hand on a shoulder can bring up these memories and cause them to re-experience the emotional component of what they experienced during the trauma or the impact of the trauma there. Dreams and nightmares associated with the trauma are very common, and so we'll get into that a little bit and ways to approach dreams and nightmares as well. A lot of the time these are startling dreams that they'll wake suddenly after, unfortunately, kind of reliving that event. Emotional flooding is where just seemingly out of nowhere emotions rise up, and it becomes this overwhelming thing. And sometimes this can just simply be the result, of stressors in external life as well. So not necessarily related to the trauma, but just general stress levels. Everybody has there's this metaphor that everybody has this emotional bucket, or this bucket of that handles their stress, and you can only hold so much of that, you can only work through so much of that at a time before eventually that bucket is full. And when that bucket becomes full, it starts overflowing and spilling outward. And once you hit that point, a lot of the time it can become very overwhelming for somebody. And so that's kind of this component of emotional flooding, or it'll make you more apt to experience the emotional flooding if you're already operating level right at the brim of that stress bucket, as it were. They might have conscious or unconscious behavioral reenactments. This can be seen a lot, especially in children. So if young children experience a trauma, they'll often act it out, usually in the only way they know how. So they'll play it out, or they'll play out the behavior or the experience. It's not necessarily children, though. Some people will, especially if severe, some people will go through similar actions to kind of reenact what happened to them, or reenact the event or the occurrence. Trauma-based hallucinations can occur, and this can be coming out of a sleeping state. So if they have the traumatic dream or the nightmare and they come out of it, hallucinations can continue after that. It can also be simply having some sort of real hallucination at any time that the trauma seems to rouse back up. And so these can be auditory hallucinations. They may hear sounds. If it's, for instance, it's not necessarily a hallucination, but it can be a trigger because it's a similar sound. For individuals who have been in the military, develop PTSD as a result of their experience, and have been exposed to explosions, and we talked about blast injuries and the impact of that on the brain yesterday. If they're exposed to that, other sounds that are very similar to that, explosive in sounds, so things like fireworks or sudden bursts or popping balloons and things like that, that can cause a re-experiencing of the event, and it can actually trigger hallucinations of other sensory sorts. So it can put them in a place where they may experience visual hallucinations as well, or olfactory hallucinations, in which they have they hallucinate different smells they may associate with the trauma. Anniversary reactions. So knowing that this traumatic event happened 2 years ago, it can bring up thinking about that, and as a result, they'll go back through those emotional reactions they had with the trauma, and so that can act as something that will bring that up and rouse those components as well. Increased distress by exposure to triggering cues. That's kind of like the balloon and the fireworks that I had talked about, different things that may just bring on that emotional flooding and become overwhelming for them, or cause them to become very anxious. Reenactment play in children, we had kind of touched on with the conscious or unconscious behavioral reenactments. Somatic memories, which trigger ego defensive defenses. That's also in line with different sensory experiences or being placed in certain positions. So as a practitioner, if you have individuals who have a significant amount of trauma, I always ask if they're comfortable being treated face down, if it's appropriate to treat face down, because if they're not, we obviously don't. That's going to make them anxious. That's something that we need to be very aware of and accommodate that so that they're not put in a position where they feel uncomfortable, or it may act as a triggering effect. And so, of course, you can treat face up, you can treat them sitting up. I have some patients with complex PTSD who don't want me to leave the room, and it's not necessarily because they feel comforted by me being there so much as they have so much trauma in their history that they want to know where I'm at. So it is comforting that I'm there in a sense because they know where I'm at and what I'm doing, but it's the anxiety that may be roused by being left alone in a potentially vulnerable position, and then knowing that I'm going to be coming back at some point. So some people are comfortable in different situations, and you need to be aware of what they're comfortable with and what they are very much not comfortable with, and be as encouraging as possible so that they know that they are in a safe space as you're working through these things with them. All right, so we've got re-experiencing as the first main defining point of PTSD. The second one is avoidance, and this can also play out in a number of different ways. So it can be an active or passive avoidance of the thoughts, feelings, or particular conversations that may discuss the traumatic event itself, or they may be conversations just generally discussing a topic that is close enough to make them anxious, make them uncomfortable, arouse some sort of emotion that's associated with the trauma. So they, and sometimes this is a matter of keeping themselves very busy, so busy that they don't have an opportunity for those intrusive thoughts to come into play. So if you have an individual with a fair amount of trauma, and they always seem to be going in every direction and they don't seem to slow down, sometimes that's a coping mechanism, and that's just a way for them to continue on, and they find if they get some downtime and they take too much time to themselves, that these intrusive traumatic thoughts or feelings kind of creep back in. And so that's something to watch out for, and just know that may be in play. They may avoid certain activities, places, or people that are associated with the trauma. If a trauma happened as a young child at a playground, then they may develop, it doesn't matter which playground it is, they may develop a general avoidance of wanting to go to playgrounds, for instance. Or people associated with the trauma, absolutely. If a trauma occurred in association with, for instance, a family member or a family friend or something like that, then they'll want to obviously avoid that situation or that individual. Emotional constriction and psychic numbing, so they just may generally pull themselves in and kind of shut down their emotions and shut down this outward movement that most individuals go through. It's very natural for individuals to go through external moving outward into one's environment and then consolidating and moving inward when appropriate, and kind of going back and forth between these two phases. Those are major phases that play out in every aspect of life. So there's expansion and contraction, both physically as well as emotionally. And so what you may find as a means of avoiding the emotions or the feelings or the thoughts, they may emotionally shut down and constrict themselves. And so they may even describe themselves as feeling numb all the time. They don't feel much in the way of anything. And whether it's conscious or not, that may be shutting down as a result of that trauma, so that they're not thinking about it or experiencing it at all. So you can have general detachment, you can have estrangement, withdrawal, that's individually, that's socially, or alienation. And sometimes these are conscious things. They'll make a decision to alienate oneself, and sometimes this is unconscious. And so they may actually participate in activities or act in a certain way to push people away. So in a way that they think is going to be not going to be received well, and may alienate themselves. So that can be rather difficult if it's not a conscious thing, because they may on the surface feel like they want some sort of emotional attachment with somebody, or to be able to emote and connect with people, but at the same time, subconsciously, as a result of the trauma, they may play out these certain behaviors that ultimately alienate themselves. Desexualization can be a thing, especially with sexual nature trauma. And so an individual may lose their sex drive or physical sensuality in general. That's just kind of an extension of that emotional constriction. When, like I said, especially if the trauma has some sexual nature to it, a lot of the time the individual will just shut all of that down, so that it's not, because those somatic experiences and those sexual experiences can re-trigger or bring up too much either sensation or too much of the previous experience and too much of the trauma. And they may develop amnesia for the trauma-related information, so they may just block that out of memory. So if that's the case, they don't really have to be avoiding it too much, so much as it's an unconscious coping mechanism that may develop. So, of course, if people are going through counseling, or if we are working with somebody and if we'll talk about the lower vessels later and how things are placed into latency within the lower vessels, tapping into that and working with the blood and the memories that are stored there in the blood and the lower vessels. You need to be aware that sometimes these memories that people have forgotten can actually come up. And so it's important to kind of do some foundational work before going into that deep level, just so that should those things come up, they're in a very safe place and in a place where they can process those things appropriately. They may have a sense of a foreshortened future, or just generally a negative outlook on life. So that sense of foreshortened future means they might feel like they don't have much of a future at all within their life, and so everything seems rather futile. Compulsive overactivity to avoid thoughts and feelings. We kind of talked about that with the first point. That's just going out and overdoing oneself and constantly keeping busy in multiple different directions, so that there's no place, there's no room for invasive thoughts or invasive feelings. Substance abuse or substance dependence is a very common, unfortunately, very common means of coping with trauma. And so people will turn to those sorts of things in order to numb it out and to not have those things, just to shut it down. So if you're working with somebody with trauma, or you're working with a good number of people with trauma, know that that can definitely be a component, and if so, that needs to additionally be addressed, either on their personal level, if it's to a degree that it warrants external help as well. Being able to provide those resources or referrals for that individual, so that they can hopefully work through that and put themselves in a place where they are ready and able to do the appropriate work to work through a lot of these. these traumas to get to a good balance and a good healthy place. They may develop just a general preference for solitary activities and work. That's supposed to be shopping, not shipping. Recreation, just general activities of life. They may prefer to do it on their own because that doesn't put them at risk for exposure to other individuals that may trigger the trauma or may seem a threat to develop a new trauma. So all of those are different ways of potentially avoiding the thoughts, feelings, or experiences that are associated with PTSD. That is the right place to put your question. So if somebody has PTSD and people react negatively to them, could that cause even deeper or new PTSD layers? So for some individuals it can. So I think what you're asking is if somebody has PTSD and then if, say, they act out in some way or they have these avoidance symptoms where they want to do things in a fairly solitary nature, or these subconscious activities that kind of have a tendency to push people away. If people react negatively to that, so if somebody tells them, you're doing this and it makes them feel bad, and you're always messing things up, and why are you always wanting to do things on your own? Or if they're pushing away support, why are you doing this? We're trying to help you, and it becomes worded in a very negative way or approached in a negative way, can this add a new layer to the PTSD? And it can be a very difficult thing for a lot of people, especially if it's not a conscious thing that they're doing, or if they can feel very misunderstood because they're doing these things in order to protect themselves and to avoid anxiety and avoid the negative feelings that they experience, the negative emotions that they experience at possible triggering events. And so will it develop a new PTSD? That's hard to say, and really depends on their vulnerability, emotional vulnerability. Can it make the situation a lot harder to deal with? Absolutely. Can it make negative feelings about either themselves or the situation more intense? Yes, absolutely it can. So it can make things more difficult, and it can possibly make them a little bit more resistant to actively working through treatment, especially if it's something that they're putting effort into trying to do these things, but they still do it in a manner that can be off-putting to the other individuals. So that's not going to be, generally that trauma wouldn't be something that would be considered drawing a new PTSD necessarily, but it'd be something that can intensify the overall experience and make things harder. Hopefully that answered the question. So PTSD can have a number of different impacts upon relationships. This can be any nature of intersocial relationship, so with significant other, with family members, going. So we had already kind of touched on alienation and that being a component, so that can play out in a number of different realms. It can be social alienation, where they kind of shut themselves in and actively avoid social situations as a whole. Emotional alienation, so that's kind of the shutting down and that emotional constriction of oneself so that they're not feeling those things. It can be personal alienation, that kind of solitary activity, or even that can be a matter of not exploring oneself at all, actively avoiding any sort of introspection. It can be cultural alienation, and that can be either actively avoiding that in any sense, or it can be acting in a contrary nature to the general culture, so you can get countercultural tendencies as well. So people may act out in a way that's counter to the culture as a means of kind of alienating themselves. Again, that can be conscious or unconscious. And in a spiritual sense, they can alienate themselves as well. So they can pull away from their, especially if they were very spiritual before, and then they experience some trauma, and they find that that sort of reaching out or expansion in a spiritual sense can seem like it's too much, or there's just a lot of those things can seem to not make sense anymore after experiencing severe trauma or significant trauma, because how could this negative event have occurred? And it can really, trauma can impact somebody on a very energetic, spirit level as well. So they may shut that down as well. Within relationships, somebody might develop just a general mistrust or guardedness or kind of a secretive behavior. So they might feel that exposing too much or talking about things too much may ruin the relationship, and they don't want to push the boundaries of that. Mistrust might develop out of a trauma being associated with some other individual. So if it's like a domestic violence situation and somebody has made it out of that situation, but that significant trauma still lingers, and the impact is obviously still there, as they may move into a new relationship, then there might be a general sense of mistrust, and the individual might need a lot more reassurance from the partner, and it may be a constant reassurance because there's just this innate mistrust that this has happened before and these traumas have come about, and so it could always happen again. So that may lead to the general guardedness, and they may feel like they're not able to do or express certain things, and so they may express that secretive behavior. Detachment, isolation, withdrawal, a general feeling of emptiness, most of those we already touched on, but that general feeling of emptiness kind of comes from that spiritual sense of shutting everything down, and feeling like oneself doesn't have a lot to themselves, either to offer, or they don't feel imbibed with a sense of spirit or spirituality. And so from that, anhedonia may develop as well. So that's a loss of pleasure in the sense of living. It's an absence of joy. It's an inability to really allow oneself to feel much happiness or joy. And so it's a little bit different from depression. Anhedonia is actually a lack of joy or that spark in life. They may also develop a repetitive self-destructive or self-defeating relationships. So we had kind of touched on that in the subconscious ways of kind of setting themselves up for self-destruction, or they may start going into relationships that they know are bad for them, just as a means of, it's almost a confirmation bias they can develop at times. So if that's the case, they're always going to, well, not always, hopefully they can work on themselves and work through the trauma to where they break that cycle, but they may develop a cycle in which they continually get into these sorts of relationships, whether they be romantic relationships or whether or not they be social relationships. But they get into these cycles that are self-defeating and they know aren't going to work out or are going to have negative impacts on the person themselves, but because they are so locked within this trauma that they've experienced, and they just continue to perpetuate the cycle until they do some self-work to kind of break through that. Okay. Just checking in on the notes down there. It looks like everything's okay. Somewhat related to that, they might develop a very impulsive nature, And that can be very extreme impulsive things. So sudden acting out, but also sudden changes in residence, so seemingly moving all the time. Sometimes this can be uprooting oneself once things become a little bit too intense, or there's too many things going on, or it can be an extension of this isolation, in which case if they, some individuals, if they start to create a firm foundation where they're at, they'll just impulsively uproot that, feeling like that foundation actually makes them physically uncomfortable, or spiritually or emotionally uncomfortable. So they may impulsively move, they may impulsively change jobs for whatever reason. Just a good number of different impulsive, sudden shifts in life sometimes. They may find an inability to generally relax or to receive nurturing affection or physical touching. So especially if it is a very intimate trauma related to another individual, that can play out into future relationships. So they might be kind of off-put by actually being nurtured or a fair amount of affection, and things like that. So they may have a hard time receiving it, or they might be able, or it may put them on edge and actually cause them to tense up and become uncomfortable. And that can sometimes act as a further trigger for a lot of play right into that re-experiencing event. As far as relationships go, they may also become unstable, or they may have very intense interpersonal relationships. That kind of goes back to the self-defeating relationships, but they may be find themselves having a tendency to have these relationships that become very intense emotionally. So that can be that can be everything from very lustful to very anger-based, and these relationships where there's a lot of fighting and a lot of yelling, they can have a tendency to kind of fall into those patterns as well at times. They may have problems establishing or maintaining boundaries. That's often a biggie for some people, where relationships are impacted. So either being able to speak up and convey what sort of boundaries are necessary for them, especially if there's a lot of avoidance of the traumatic event themselves, within themselves, and not wanting to really talk about it too much or address it, then they may have a very hard time saying, okay, I have this trauma in my life, and as a result, these sort of things are going to be helpful, and this is what I need from you. But they're not even consciously wanting to work that through internally for themselves, so they're not going to convey that externally. They're not going to express these boundaries. Or if it was a situation where boundaries were very much broken in the past, they may become very passive or very submissive about discussing boundaries and what's appropriate, or maintaining them. So if those boundaries are breached, not doing too much and just kind of putting up with it as and addressing those sorts of things that are very important for anybody, but especially if you you have experienced a significant yes. Anxiety is also common. So just even if the relationship is a good, healthy relationship, there may be this underlying sense or fear that that individual is just going to leave, or that their social group is just going to abandon them at any time, no matter how supportive they may be at any point, even if that's never wavered. If they have that history of trauma, they can have that underlying sense or fear that abandonment may happen. Yes, boundaries with their healthcare provider, that's very true. Asking too many personal questions. Yeah, so You need to try to be as cognizant as possible about what they are comfortable talking about and what they are not. So I will generally ask, working with a lot of people with brain trauma as well and physical trauma, I leave it as an open-ended question on my questionnaire, asking if there's any significant trauma in your history. So that way it's nice and broad. It could encompass physical trauma, it can encompass emotional trauma, and if they're in a place where they don't want to talk about it, and it's not put down there, then it won't be put down there, and I'm not going to touch on it too much. If something stands out and it seems like it may be there, I might kind of hint at it in very subtle ways and let them kind of know that if you want to discuss this and we want to work on it, we can definitely do it. But you don't want to become pushy about these things. You don't want to put them in a place where they become overly guarded, or where it feels like where you're pushing beyond boundaries that they're comfortable with or boundaries that they have established at this point. So it is a delicate balance as you're getting in there. How do you know if this is related to PTSD versus just having a bad day, week, or month? If you're working with them as a patient, you can simply ask if they have any significant trauma. If they meet the diagnostic, at least here in Oregon, I'm not a primary care physician, so I can't make formal diagnoses of PTSD. So a lot of what we're talking about here is general trauma as a whole, and then what PTSD is and what it's defined as within the Western realm. Of course, Chinese medicine didn't have a condition called PTSD. You were approaching trauma or heart shock, which we'll talk about both of those. We had gone over the definition of what PTSD is, so it's those three components that we had talked about. The avoidance, the re-experiencing, and then our next slide, structure of self, and the emotional trauma. So if that has lasted for more than a month and it's severely impacting their relationship, that's what defines it as PTSD. But really, if they're just having a bad day or a bad month, and you broach that with them, and you can discuss that with them, you can find out if there was significant trauma in their history, and if there wasn't, then chances are that it's just a bad day or a bad month, or some such. And also sometimes the degree at which these things are manifesting, or the consistency at which they're showing up. The experience that everybody has some sort of trauma. I mean, we're all humans going through the human experience. We've all had these situations that we've had to deal with, these positive experiences, negative experience, and the degree of that and how much it impacts us, and how we cope with it all kind of play into these sorts of things. So we're talking about situations where the trauma is continuing to impact their life at a pretty severe rate, so where it warrants being addressed clinically. All right, continuing within the definition of PTSD, ways in which the trauma can impact one's structure of self or sense of self. And we'll talk about the neuroanatomy, or the neuroanatomy of how this happens in the areas that are associated with this in a little bit. But these are not always the case, and keep this in mind for every element of these that we've talked about so far. Like, everybody who has PTSD is not going to experience each one of these. All of these can be in play. They're common enough to be noted, and if you are seeing a lot of these tendencies, to know that might be a result of the trauma. So pertaining to structure of self and how it can impact one's sense of self. An individual might develop narcissistic or other personality characteristics. This is a damage to one's self-structure. So narcissism, they get this inflated sense of self, but generally underlying that is an insecurity, and so they're overcompensating and sometimes demanding a lot of attention or getting as much attention as possible as personal reassurance. And that's because the sense of self doesn't have a firm foundation of security. So that can come in play. Demoralization, dysphoria, essential doubt as to life's meaning. So that kind of plays into the anhedonia and one's general feeling very depressed about life, and that there may not be much meaning at all, and it's all pretty pointless, and why am I even going through this? It may be loss of ego coherence, so their sense of self, their sense of self or ego may become fractured to a degree. So you can get, we'll talk about dissociation in a little bit. In severe cases, of course, you can get things like multiple personalities and these splits within one's personality or one's ego. So those are very severe cases, obviously, but it can occur following as a result of emotional trauma. You can get fragmentation of the ego. The ego identity and identity disturbance, it's kind of the same thing. They may experience a lot of shame, self-doubt, a loss of self-esteem, guilt, or self-recrimination, and these can be, generally speaking, they may just generally feel guilty about life, or it may be self-directed. So they may feel very shameful about the experience that they had, the traumatic experience, and as a result, not feel very open about it, not want to discuss it, not want to approach it too much, but that shame component, or they may feel guilty that something happened to them, or even if they were not responsible at all for the event, they may feel as though they were. They may take it upon themselves and feel guilty about that. You may have fluctuating ego states, may have a general sense of hopelessness, helplessness. They might develop masochistic or self-destructive tendencies, or even suicidality in extreme cases, obviously. So this is a turning inward, turning one's negative emotions that they're feeling about the trauma in this external event, they turn it inward toward themselves, and so may develop these tendencies. Existential, personal, or spiritual angst, a general sense of dread or despair, a sense of futility. They may develop misanthropic beliefs, so that everything is working against them, and again, there's no point, and everything just works in a very negative way. They may become very cynical, either about the world or about people or about certain subsects of people that fit into a category that is associated with the trauma. May develop these broad general views that this subsection of people in general are bad. They may develop a view of the world that is very unsafe or dangerous, and so because of that, they'll continue to avoid it, like we had talked about. So they just have this general sense that everything around them, or the external world, or people are unsafe to have some sort of interaction with. And as a result of that, we had talked about that closing inward and that isolation. So they'll just shut everything down because it's not safe to approach. Okay. All right, so let's go ahead and continue on. For those who attended yesterday, we spent 8 hours talking about brain injury and the different ways that can impact and a lot of the symptoms that are associated with that. What we're going to go through as we get into the neuroanatomy and how the brain and the body responds to PTSD, you're going to find a number of similarities between brain trauma, and the physiological effects of PTSD. And reason for that is that emotional impacts and emotional traumas have very real, measurable physiological responses. And so it can be helpful to kind of lay out and see there is a lot of comorbidity in this. Like I said, for a lot of my patients who have a brain injury, a number of them have PTSD and an emotional trauma associated or in play there. So it can be kind of helpful to suss things out and see what the differences are and what the overlaps are as we get into the neuroanatomy and seeing the similarities there. So if we start in the center box, certain symptoms are found in both PTSD and in traumatic brain injury, physical trauma to the brain. So fatigue is very common. General sense of irritability is very common. Yesterday we talked about irritability being the #1 indicator for severity of brain injury symptoms. Insomnia is very common. Depression and cognitive deficits. So that can be anything from this fuzzy feeling within one's head as if everything in their head is kind of clouded and not coming together. It can be difficulty finding words. It can be just kind of shutting down cognitively. In PTSD, you can have the flashbacks or that re-experiencing. You have the avoidance symptoms. You have the hypervigilance symptoms. So those are the 3 key ones. Those are the 3 defining ones. Re-experiencing, avoiding, and hypervigilance. They may also have nightmares, and the re-experiencing flashbacks are kind of the same thing. So just different ways of, a flashback is a different way of re-experiencing. Whereas with brain injury, you get much more physical symptoms. So a lot of people will have headaches. It's a very, very common symptom. Nausea and vomiting as a result of dysregulation of the vagus nerve. Photophobia is very common, light sensitivity, sound sensitivity, and vision issues. We had talked about the brain, or the eyes as an extension of the brain, and when you have physical trauma to the brain, it can often throw off the vision system, visual system. So just being aware of these overlaps, and again, as we get into the neuroanatomy of things, knowing that there are similarities and there are differences as well. Okay, and we can talk about the organismic effects of PTSD, so how it affects the organism, the human organism as a whole. I've got the reference down here that you can refer to if you want, but it says at the organismic level, post-traumatic adaptations include individual subjective responses and reaction patterns in terms of 5 unrelated psychological processes. So it affects emotional regulation or affect modulation, the ability to emote or express oneself. Can impact cognitive processes and information processing. We had already kind of touched on that in the last slide and how that can overlap with brain injury. So it can actually, people will develop difficulty with cognition, difficulty thinking through things, and sometimes that's an avoidance type situation, and sometimes certain areas will just shut down, and so we'll see that the frontal lobes can be affected by PTSD, and that can directly impact cognitive function. PTSD can also affect motivational predisposition, so need-based or goal-oriented behaviors can be impacted. They might have a difficult time registering their needs, or they may cater simply to their needs and avoid any sort of what might be considered superfluous behavior, anything that might not seem to make a lot of sense because it's in pursuit of joy. And so any sort of silliness or play or fun, some individuals will shut those sort of things down because it can be too emotionally arousing. Psychobiological processes, which we're going to spend a decent amount of time going over, and it can also affect ego defenses, various coping mechanisms that we have kind of talked about, systems of belief. So if they have certain belief systems and a trauma occurs that breaches those and seems to discredit those sorts of beliefs, that can be very disorienting for an individual. A general sense of meaning and spirituality, which we had kind of touched on. So the question is, as healers, would it be correct to assume that we will experience secondary PTSD from our patients eventually? The answer to that is no, but you need to be very careful about your own self-work and your own personal boundaries. It can be very difficult to work with, and it's a matter of not taking too much on. So when I first started practicing in clinic, when I was still in acupuncture school, that was the first and hardest lesson that I had to learn rather quickly when I started seeing patients, is I would quickly start to take on their own symptomology, even physical symptoms. Somebody was coming in with headaches, could alleviate the headache for them there during the treatment, but 3-4 hours later, I would start to develop a headache or something like that. And I had to quickly realize how to have a good functioning personal boundary system to where those things are not taken on, but you're still able to be compassionate, you're still able to be empathetic, but realize that those things are not yours. You are working as a conduit or a vessel to allow for their own healing process. You're helping them facilitate their own healing. And so it can be a delicate balance sometimes, but we're going to learn a number of different ways to approach these for our patients, and these are things that we can adapt for ourselves to try to ensure that we don't overexpose ourselves. We know what we are capable of handling, and that it's not going to negatively impact us as practitioners, because that's going to ultimately impact our patients down the line as well if we're negatively impacted, and we don't want to take those things on to or move them onto our patients, other patients. Yeah. Agree with most of what's being said there in the comments. So going on with organismic effects of PTSD, there are 5 sets of basic psychological processes that are associated with forms of dissociation found in PTSD. So dissociation is a loss of sense of oneself. The extreme of this is having kind of an out-of-body experience. You don't feel as though you are in your own body, but you can have emotional dissociation in which the emotion is there, it's present, but you've removed yourself to a degree to where it's you're not actively experiencing it so much as observing it. And so dissociation can be fairly common in PTSD and can play out in memory and information processing. It can play out as self-detachment, altered states of awareness, and sensory changes. So it's kind of that altered awareness is kind of that out-of-body experience, or they may consciously or unconsciously be forced themselves or be forced into this altered state of consciousness. A continuity in ego processes we have kind of touched on already. They can have sensory, perceptual, kinesthetic levels of awareness which shift. And so if, as far as sensory type stuff, we had talked about a hand on a shoulder that may stir up emotion. Somebody may completely dissociate from that if that's the coping mechanism, if they're in a position where they can't get away from that situation for whatever reason. They may separate themselves to where mentally they're not processing that sensory stimuli, they're not processing that sensation or the perception, things that they're seeing. They may, it may get to the point that they completely block out certain events or certain things that they're seeing or experiencing so that's kind of selective amnesia in a sense, so that they're not having that rousing of emotion or trauma. And you may get ego fragmentation within the organism of the self as a whole. All right, so we talked about what defines PTSD, and we've talked a lot about the different aspects of those components of what define PTSD. More recently than PTSD itself has developed the term complex PTSD, or some people will come to you and tell you that they have CPTSD. And so what that means is it's generally sequela from an early childhood trauma or abuse or neglect. And so this has a lot of the foundational components of PTSD, but it's further developed with the following symptoms as well. So we had touched on dissociation. That's a very common occurrence, certainly more common with complex PTSD than it is with what would be considered standard PTSD. You can certainly get dissociation symptoms, but with complex PTSD, it's much more common. The relationship difficulties, which we already touched on, those can be much more prevalent. Re-victimization, so that can be either having nothing to do with them consciously, so it may be they were put in a position in which they were a victim multiple times to multiple traumas, or this may be a situation where we kind of talked about that self-destructive, self-defeating behavior in which they place themselves in situations where they may be prone to being victimized again. Obviously, that's not healthy behavior, but it's a pattern that some people can fall into. Somatization, so physiological symptoms, physical symptoms that come about as a result of emotional or mental states. So it's not caused by any sort of injury, but it's a somatic experience, somatic pain or restriction or blockage or stagnation for whatever reason as a result of the emotional and mental components. They may have affect dysregulation, so they may have a very stoic face, or they may seem to lack a lot of emotion in their expression. So that can be facial expressions, that can be in their tone of voice, that can be in the amount of expressiveness of their body movements and their and they may be very rigid and hold themselves very rigidly as a result. They may have disruptions in identity as well, so we've already kind of touched on that also. That's where they either they don't have an established sense of identity, they don't feel like they know who they are, or like they have a foundation of foundation of self, or it may be where you have that fragmentation of ego identity, and so they may have kind of shift between a lot of different emotions or a lot of different mental states, or in severe cases it may be where they actually feel like they are different people at different times. All right, so we'll go ahead and talk about factors that play into the development of PTSD. There are factors prior to trauma that can play into it or make somebody more prone to developing PTSD, where they're having these avoidance and re-experiencing and hypervigilance symptoms. There are certain factors at the time of trauma that can further impact the development of PTSD or whether or not it develops into PTSD, and then there are certain factors after the trauma itself that can play into whether or not it develops. So prior to the traumatic traumatic event itself, these pre-trauma factors, any sort of ongoing life stress or demographics. So we kind of talked about that bucket already, where if somebody has a lot of stress in their life and it's a continuing thing, and that bucket is always sitting near the brim or almost full, then this trauma can set it over the tipping point to where it spills over. And so that's going to make you more prone to the development of PTSD. It doesn't guarantee, but in situations where you have ongoing life stressors, it can make you more prone. Lack of social support in general, so having a good social support system allows oneself to have a good firm foundation and a good sense of self at times, but having that support can be helpful, and that's going to play into after the trauma as well, having that support in dealing with the trauma. But even before any sort of trauma happens, if you've got that support system, it can be helpful for the individual to be able to cope with the trauma as it happens. Young age at the time of trauma is certainly influential. So the younger that a trauma occurs, the less self-work that they've done, the less development of ego and identity that they have, and so it becomes much more fragile. Or it doesn't become much more fragile. It is much more fragile because it's not as consolidated, it's not as firmly established. And so the trauma itself has a much deeper impact, and we'll talk about that again when we get to the low vessels, and how when the trauma occurs can have different impacts on the individual, and what sort of symptomology that they experience, or how deep on what a deep level the trauma can impact them on. Any sort of pre-existing psychiatric disorder is going to predispose them to the development of PTSD. Low socioeconomic status, education level, intelligence, their gender does play into it. A lot of this comes down to, again, the foundation, having that foundation or that sense of self. So if you're coming from a low socioeconomic status, you may not have the resources to either feel like you've got a firm sense of self, or you may not have the resources to properly address the trauma as it occurs. Okay, kind of checking in on the chat, so it looks like everything's good discussion, but not much in the way of questions. So we'll kind of continue on. Any sort of prior trauma exposure, so childhood abuse, of course, reports of previous traumas that they may have already sustained, other adverse childhood factors, a family history of psychiatric disorders can also be a predisposing factor. So again, these are all things that may be in play should a trauma occur, should a significant trauma occur, and these factors are in play. It does increase the likelihood of the development of PTSD. It doesn't mean that it's going to happen, but it does predispose them. Divorce can certainly contribute to PTSD because that can be a very significant emotional trauma. That can be a triggering event, or if that's something that somebody has gone through previously, that's certainly a trauma for many individuals, most individuals. And so how they work through that and how it impacts them is going to vary from person to person. It can be a predisposing factor, so it can be a prior trauma that another significant trauma that happens down the line may actually develop the PTSD from, but it can be a predisposing factor. Or it can be a factor in itself where you can experience PTSD as a result of the divorce. So yeah, absolutely, it's considered a trauma. peri-traumatic events or factors at the time of trauma that can predispose or make PTSD more likely to develop is the severity of the trauma itself. So the more severe the trauma, generally speaking, the more likely you are to develop PTSD. The type of trauma that'll play into it, so interpersonal traumas, very severe things like torture, rape, or assault convey a really high risk of PTSD. So those impact somebody on a very, very deep level, down not only physically or emotionally, but down into a spiritual level. And so those sorts of things are very intense and more likely to develop PTSD as a result. Anything where there's a perceived high threat to life, so anything that feels like you could have died in that situation, is a predisposing factor. Community or mass traumas tend to have a higher rate of developing PTSD as well. So natural disasters, 9/11 even could be argued our current situation, and depending on how people, how it's impacting individuals. But situations where there are a lot of people involved and there's this mass trauma have a higher tendency to develop PTSD. So self-work right now, very important for everybody, to find good coping mechanisms to deal with our current situation and what we can do with it so that it doesn't hopefully impact us too strongly. And then peri-traumatic dissociation. So if it's a situation that's so severe, and again that plays into the severity of the trauma, but if it's something that causes somebody to need to dissociate, to remove themselves from the present moment, and remove themselves from their sense of self or their sense of body, then that's also a factor that predisposes oneself to the development of PTSD. Prenatal trauma absolutely has been shown. So that's been, as we get into the neuroanatomy, that's been shown to, impact slightly different areas of brain development, depending on what stage of development somebody is in, and it has been shown that traumas during development of the child while in the womb can play out and have an impact on further development, both physically and emotionally. And then post-traumatic factors, so factors after the fact of the trauma. And keep in mind all of these are in play and can have varying impacts. But post-traumatic factors is, again, ongoing life stress. So if you've had a traumatic event, but you have to continue on in a very stressful situation in your everyday life, or through a good chunk of your life, then you're sitting with that bucket right on full as a result of the trauma, and so those additional stressors or those ongoing stressors will just continue pushing up that level to where it spills out and can cause you to develop PTSD. And it's not always, PTSD symptoms are not always showing up immediately after a trauma. So sometimes somebody will go through a trauma and be able to cope for a little while, but if they have a lot of life stressors going on, kind of reach this point where everything becomes too much, it becomes overwhelming, and this re-experiencing of the trauma can start to come up and start to be re-experienced. Lack of positive social support, so we talked about that as a pre-trauma factor as well, but having a strong support system as a means of addressing the trauma, either directly, so it's people that you can talk to, people that you can turn to, or not directly, not discussing the trauma at all, but just being able to have people around you, or being able to have a support system that's there should you need it or as you need it, or just generally feeling like you have that as a firm foundation. Negative social support, so negative reactions from others. That was asked as a question. It can be a factor that predisposes people to PTSD in the same sort of sense as the lack of positive social support. So if you're getting negative social support, you're getting a lot of negative feedback. You're told, if you start being told that you are crazy because you're having issues with dealing with this trauma, it's going to start to make you feel like that is the case, or it doesn't help with one's self-esteem, and so those sorts of things can further the development of potentially having PTSD. Bereavement of any sense, so great losses in life, that certainly includes divorce, loss of loved ones, even whether it be death or whether it be people, your social support moving away, or significant individuals in your life not being there anymore. We had talked about abandonment anxiety. If there is a sense of abandonment at some point, that can also act as a predisposing factor. Major loss of resources, it kind of goes back to the low socioeconomic status, or if we don't have much in the way of either physical resources, so living situations, steady food situations, just a good solid foundation for oneself, or emotional resources. So again, people that they can turn to or lean on, resources in any sort of sense. If there is a major loss of any of those sorts of things, it can be very destabilizing for the individual. And any other factors, including children at home or distressed spouse. This was again pulled from the text that's referenced right here. So the Treating Psychological Trauma and PTSD. But basically what that's coming into is if there's a lot of stress in one's household, and there's a lot going on, and you have a difficult time, or the individual has a difficult time coping with those sorts of things, or it's just constantly going, there's no downtime to really focus on oneself, or to work through the trauma itself. You have to just kind of keep barreling through. That's going to continue to play into that stress level and push things over the brim. Let's see. Society has such a tendency to downplay the post-traumatic events. That's very true. I mean, the awareness of PTSD and the awareness of emotional traumas and how much impact it can have on a person has gotten more attention and is more recognized, for sure, over the last few decades. But a lot of the time, it's not properly addressed, and a lot of people don't know how to properly address it or properly support it. And we've definitely, as a culture, have this mentality of, okay, we recognize that this may have happened to you, but that's not necessarily going to slow down your life. You kind of got to deal with it and get back out there, unfortunately. So that can make things very difficult. And as we talked about, that continued stress can predispose to a lot of the symptoms of PTSD and have these physiological effects that we're going to talk about in just a couple minutes. I think the shame can be about the event, but also often about the inability to handle the event, shame that we can't bounce back. That's absolutely true, Cindy. So shame and that sense of guilt can play into both components. So both the event and the experience themselves, and they can feel responsible for that, and as a result feel shame. But yeah, if you do not have a support system that's receptive to or understanding the impact of the trauma, and or not understanding the fact that somebody may need to take time to really process this and work through the trauma itself, you can feel guilty, or the individual can feel guilty or shameful about that fact. They can feel bad about having to take time for themselves and to do some self-work. And if both are in play, then it just can become rather troublesome emotionally for them. It can be kind of tumultuous too. to handle that on top of having this trauma that's happened to them, to feel bad about it and to feel bad about not being able to bounce back immediately like it was nothing. Well, if there's a significant trauma, it needs to be properly processed. So I think yeah, so like I said, in the last couple of decades, it's gotten more recognition, and so to a degree, I think culturally there's a little bit more understanding, but there's still very much a pick yourself up by your bootstraps mentality of like you kind of have to deal with it. Fortunately, the discussions about going to therapy are much more open now, so whereas in decades previous, it was faux pas or taboo to kind of go to therapy and work through your issues. It's much more openly discussed at this point, and working through one's issues or expressing that you've experienced this sort of trauma rather than having to keep it to yourself and hide it and try to move on. So, all right, so it is 10:30 or just about 10:30, and I think this is a good stopping point. Yeah. So when we come back, we'll go ahead and start talking about the statistics and the neurobiology of PTSD and how it affects us on a physical level and our nervous system as a whole. So let's take 15 and we will come back about 10:45.